In terms of respiratory support, early non-invasive ventilation, minimally invasive surfactant therapy are the ways to go. If a baby does need invasive ventilation, aim to extubate early. Avoid using routine sedation. We often underestimate the effect of sedation. Sedation, especially not only the pain relief, but using midazolam, etc., deep sedation or paralysis, causes a significant shift in different parameters. So you lose the baby's automatic PEEP through the endotracheal tube, but the baby's effort to clear the secretions is totally lost. There is more secretions, more need for suction. There is a third spacing of the fluid in these babies. Edema comes in. You lose the effect of the diaphragm in supporting the breathing, the chest wall muscle tone in maintaining the compliance. So you're losing so many parameters, and so you end up needing more ventilation. There are many studies which show that using sedation has both short-term adverse effects like needing more ventilatory support and long-term effects like delayed extubation and even impact on neurodevelopment. So think carefully and use deep sedation only for very minimal times once the baby is stable, and consider the impact of these medications on blood pressure. So because you're giving deep sedation and third spacing and pooling, etc., you may need more inotropic support, and the inotropes are not safe either. So any additional medication has impact on your system that you don't see. Another example of medications where we don't clearly know the impact is a diuretics. So when we use a diuretic, there is no clear evidence that the diuretics work. At the same time, you may end up causing electrolyte disturbances, and you may need to monitor their blood tests more carefully. Because of that, they don't gain weight well. Then you start doing more interventions for the weight gain and so on. So use diuretics for 1 dose or 2 doses at a time if needed. So BPD, it doesn't change anything. Avoid using diuretics for a long period of time. It's more a habit than a benefit. In terms of suction, avoid routine suction. Teach the nurses to look at the ventilator graphics. Avoid routine blood gases. Do gases on non-invasive ventilation only as needed. And end-tidal carbon dioxide monitoring can be used. When you are ordering a blood gas, think about whether it's likely to change your approach. The baby is in 30% oxygen, is comfortable breathing. Are you going to re-intubate the baby? No. So you don't need a blood gas for that. I mean, you may do once in 1 to 2 days, and we often move to once in 3 days on babies on CPAP, for example.